So, good evening and a warm welcome to all the dignitaries present here. I'm Sreushi from Clanet, serving as the allocated session assistant to ensure a seamless experience. Clanet stands as India's most relied upon digital platform, offering a multitude of enriching services exclusively for doctors. It is with great pride that Clanet serves as the digital partner for this event, hosted by the Indian Academy of Pediatrics National Respiratory Chapter, and the focus of today's session is Inhalation Therapy Part 1. So let's begin today's session, for which I would like to invite Dr. Narayan Prasad Modi sir to take over. Over to you, sir. Kindly proceed with the talk.
Thank you, ma'am. Am I audible?
Yes, sir, you're
Yeah.
audible.
Yeah. So, thank you, Clarinet, and thank you, Dr. N.K. Subramaniam, sir, to have given me this opportunity to be on this platform. And I have one slide CV for Dr. N.K. Subramaniam, but actually it will be a book if I am to describe him and his academic prowess. Dr. N.K. Subramaniam, he is now Medical Superintendent and Professor of Pediatrics, PES Institute of Medical Science and Research, Kuppam, Karnataka. He is our past General Secretary, past Chairperson of IAP NRC chapter, and he is also Vice President South Zone IAP 2022. But this much I will pick up from his slide. Rest of the thing I will introduce by my own. Dr. N.K. Subramaniam, he knows science, he knows physiology, he knows respirology by back of his hand. If I am to summarize him, sum up his prowess, I will speak this sentence about him, that he knows science and respirology by back of his hand. The prolific speaker, very, very popular amongst pediatricians all over the country. And he makes everything so lucid, clear, simple, that all complicated things of respirology. And if I am to speak personally, I used to hate, in fact, respiratory medicine. But since last 5 years, coming in contact with Subbu Bhai, he has done a magic sort of on me, and it has become my passion, pediatric respirology. And the topic that he is going to speak today is aerosol therapy. And aerosol therapy and aerosols. Now, post-COVID, even a standard 5 student knows something about aerosol, wants to know about aerosol. That has the effect that COVID has caused globally. Even a school student now wants to know what is aerosol. So this is the bane of COVID pandemic to humanity. And you can all be sure, dearest delegates who have joined, spared their time for this wonderful scientific CME on aerosol therapy. I can assure you that by the end of the session, probably part 1, 2, or maybe 3, that you will be a master on aerosol therapy, which has become the real essence of modern respiratory therapy. Across all, means asthma, infections, chronic respiratory illnesses, everything. And not to talk about the treatment and management of cancers also. So that is all from my side, and we'll take all your questions at the end of the session. I am there, and Subbu Bhai will be there to answer all of your queries. Over to you. The floor is yours, Subbu Bhai.
Thank you.
Thank you.
Dr. Modi, I have got one request for you. This inhalation therapy may be over 1 or 2 or 3 or 4 sessions, I don't know. Therefore, I would request you earnestly, you be moderator for all the sessions. It will be my pleasure. No, we want one person to be
Me
there
too.
before. No,
Mine
the
too.
point, there are two reasons for this. One, if there are difficult questions, I'm proud that you are equally uh, being the coordinator of advanced asthma program, you can also answer from many, and you are a passionate allergist by nature and very smiling a person and very friendly person and a teacher of pediatrics and professor. So you can also add some values to the delegates who are attending. This session is a free flow for everyone. What I planned today was to take some part of inhalation therapy, not cover everything today. Please understand, and then I will take up questions, but do not worry. The videos, the techniques of inhalations, the mistakes that we do, real life, everything will come in the subsequent sessions. Today will be a bit dry session for you. It's a starter for you, but do not worry. But the point is that I would request you to attend all the sessions sequentially. And my request is that save my WhatsApp number. I will share you the PPT. You don't have to take down anything. Number one. Number two, you please give what you want in subsequent sessions also. I will add those slides for you. For example, sir, you add more about nebulization. I will add. You want more about MDI. I will add. You want to know about prices in India. I will add. You want to know more about statistics. I will add. You wanted to know more about how to talk to the parents. I will add. Are you getting my point? So all the viewers and it's not my session. It's your session, and I will go on extending to part one, part two, part three, part four, as you would wish, and as long as the Modi could support me. And this is how we want the flow of science, and let the aerosols reach up to you. That's what we are wishing rather than what we want to speak. It's more what you want. Please feel free, message at the end of the session what additional things are difficulties at your level. See, that's very, very important for us because that's how we would cover the complete topics. This is all about inhalation, and one of the most uh, I would say easiest topic, because most of your trainers in asthma training module or inhalation therapy, that program ran by CIPLA, by the National Respiratory Chapter, by IAP, under five easing, this, that, etc. You have been covering this. But what I would wish is that over 3 or 4 sessions, or maybe over 1 or 2 sessions, um, you would be able to completely hear from me. I think somebody is telling my voice is low. I don't know what to do for this. I'll just try and see. Is it a very low voice?
Exactly. Bye.
How to increase the volume? I don't know. If it is okay, then type okay, no? Okay, I will little speak little loudly. Okay, fine, fine. Maybe somebody has typed low voice. That's why.
No, it's okay.
It's okay, means fine, fine. I will not change any settings. Fine. Thank you. Now I'll start sharing the screen, and maybe in next 15-20 minutes, I or maybe in 30-40 minutes, I'll try to speak as much as possible. Don't worry, the remaining will be covered in the subsequent sessions. So this will be only starter for you. I'll start sharing my screen. My opening remarks would be on the same. There was lot of demand for inhalation therapy. Modibai, let me also tell you that many pediatricians who met me, sir, we want some clarity on respiratory tract infections. So I formed some WhatsApp groups with invitation. The groups are full. I had to make 2 to 3 groups, and the people are flooding in. I'm sitting with technical team to devise that none of you should be disappointed, and therefore give me some time that we will work up with our team to come back to you to see that every one of you will get confirmation of registration. You have all, majority of you are there here, have provisionally registered. We will see that everybody registers, get feast of academics. Only for the sake of convenience, I have made mono speaker, but that does not mean everyone, all my friends will be the speakers in turn for invited lectures. That's only to keep the content of the topic with a bit of conflict of interest that I had to deviate to what we want to do by the demand of everyone. So therefore, it will be covered, and I will move on to today's
Bhai,
concept on
sorry.
inhalation therapy. Modibai, you want to tell anything? Please go
Yeah.
ahead.
Before you start, bhai, just one query.
Please.
You have that Aishwarya Rai slide in, no?
No, 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 not there. It's there at the end.
Okay,
The
okay.
end for everyone. So that won't be at the end of all sessions. So thank you. I think now that many are comfortable, let me start the session for today. See, there are two things, two words that are used: aerosol therapy and inhalation therapy. Inhalation therapy is commonly used in the context that we are using. In asthma is most commonly used form of inhalation, aerosol therapy. Aerosol therapy is a broader term. You refers to a colloid system in which a solid or liquid particles are suspended in gas. Aerosols are there everywhere. Aerosols are there in therapy. Aerosols are there in infections. Aerosols are there in industry. Are you getting my point? So therefore, that's a different aerosol used for therapeutic purposes, and inhalation part of it is what is being used in asthma and its brothers and sisters. I'll give an example. For example, Crow. So you have used this in various platforms. Now, for time being, for today's discussion, let me focus on asthma and mainly on asthma requiring aerosol therapy. I will also discuss the diseases that require aerosol therapy or inhalation therapy in other diseases as well in subsequently. What's the challenges that we face in inhalation therapy? Let me start from the challenges because this is what happens to many pediatricians. I definitely agree with all of you that, ultimately it is the challenges that will actually trouble you, and most of you. And I agree on this point that, when you are faced with these challenges, you feel, oh my God, why did I advise inhalers to this patient? I lost them. That's simply because of poor compliance. It's because of overuse of beta 2, underuse of steroids, and most patients achieve only to fail. So the point is that in a recently published article in Lancet, uh, they said that more than 90% of the asthmatics fail to achieve control and adhere to inhalation therapy. They will adhere to smoking, but they will not adhere to inhalation therapy. That's simply because the nicotine is addicting, whereas none of these drugs are addicting as the patient would feel. But unfortunately, I wish that many drugs of inhalation therapy were to be addicting, so that, they feel like taking inhalation therapy. Maybe that's the way forward in the science. See, develop some addicting drugs so that they would rather stick to the therapy, and, they will take it for quite some time. That's only in the context. Please don't take it from me that we wanted to have an addicting drug, but I wish that they would have been addicting, so that, they will take. Now, let me come to some concepts of where this inhalation therapy goes in. It gets into the airway, and you need to understand that you can't push something to the airways. Airways, they do divide, 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 and, when you inhale something, the resistance is there maximum in the upper airways. As you go down, the resistance to the flow is reduced, and the particles decelerate, and they reduce in velocity, and they spread across a good surface area. Are you understanding my point? Like, you have a small throat to swallow a cup of water, but when it goes to intestine, it stretches very widely, and then it has a large surface area to get absorbed. On the similar scene, here you have a conducting part of the airway which will not absorb any of these aerosols that you would inhale, which is predominantly upper airways, mid airways, and 4 to 5 generations of airways. And you have smaller generation of airways, which we call as smaller airways, which starts maybe from 20th generation to 25th, 21st generations. So those are the last 4 to 5 generations of airways are the ones where, you have these, the so-called medium and small airways. That's where the inflammation is maximum. And the last part of it is respiratory bronchioles. That's where you don't get any inflammation as much as you would expect. And And in only pneumonia, you get inflammation of the alveoli, parenchymal inflammation, asthma is hardly anything. If you can get proximal inflammation of the airways also, but only during acute attacks. So therefore, my dear friends, it is very, very clear that you have a conduit system that should carry these aerosol particles inside. Why I'm making you understand airway characteristics. Most of the times, there is touch me not kind of response. Do you all remember the touch me not plant? Sorry, I didn't get a picture of this. I would have put the picture of the touch me not plant. When you touch that plant, it will move. So airways are similar. A cold air, a blast of air, a foreign particle, or even un humidified air. Whenever it enters the airways tends to constrict and goes to spasm. And when it goes to spasm, there is a variable constriction that happens. It's not uniform constriction. So what happens by non-uniform constriction? Physics. Can anybody tell me? The air flow becomes turbulent. If you want, I can type it for you. It becomes turbulent. And when it is turbulent, it doesn't reach where it should reach. All the particles get deposited here and there. It won't reach to medium and smaller airways. It will all get deposited proximally. So therefore, bronchospasm will not only restrict the flow, it will make the flow turbulent. And why I'm discussing this is because that's why when you are fine, if you take a single puff or two puffs of bronchodilator, you will be all right. But in an acute asthmatic attack, you need repeated doses of salbutamol. Did you understand? Any one of you can type yes for me. Because these airway characteristics have to be understood by you as to why you need repeated doses of salbutamol in an acute attack. On the contrary, in a chronic asthmatic, not in acute flare-up, a single puff of salbutamol will relieve him. And therefore, what he tends to do is he will continue to use beta 2, but not steroids. Please understand this point. This is very, very important. And you need to understand airway characteristics. And that's so nice of you. I just wanted to keep you, many of you awake. That's why I asked you to type yes. One or two of you can type yes also. That's fine for me. Now I'll go further. Now this is very, very important. And the second one, which I'm showing you, is in acute flare-up. That's when you have problems. Now, further, if you have nose block and allergic rhinitis, what happens to the mouth breathers, adenoids, obese? Now, do you think they will have beautiful lamellar airflow? If you're obese, you will tend to collapse. Parts of the airways don't open up. Some of the airways will be open. Some of the airways will be collapsed. Are you getting the point? Many physical characteristics of the build, disease, the activity, exercise, non-exercise, sleep, posture, left lateral, lying, prone, supine will all affect the aerosol delivery. Did you like this concept? It's very, very important. Now, I think I've answered to you most of the questions that you will ask. Sir, can I give MDI with spacer in sleeping position? Can I give in lateral position? Can I give after food? Can I give after drinking water? Can I pinch the nose? All this, please understand. You don't dictate the mothers, but please understand. Ask yourself a question. Will the airway be patent and open to inhale freely and in a lamellar style? This question, if you ask, you'll have answered all of them. You don't need any science to understand this. Now, what are the barriers to achieve a lamellar flow? In asthmas, airways are varying in caliber, not just because of just the bronchospasm, which I was talking to you just now in view of polyphonic V's, which you see variable obstruction. It's also because of inflammation. Because of the inflammation, the caliber gets reduced. And when you have a viral infections further, and what is the difference between a child's breathing and an adult breathing? Can anyone of you tell me what is the respiratory rate in a child versus an adult? Childs breathe more number of times per minute. They are shallow breathers and they are turbulent breathers. You ask a child, show me how you breathe. You watch me what I'm trying to do. It will do like this. Whereas an adult, he will do quietly. Are you getting the point? And therefore, younger they are more turbulent. Younger they are more shallow. And medium, small, and smallest of the airways may not be that good to receive the inhalation therapy. Let me tell you further. Did the children like to inhale or exhale? Any toy that you give to a child, be it a balloon, be it a whistle, it acts by the mechanism of exhalation. The children like to exhale, they never like to inhale, and it's a practice. Those children who does yoga or singing, some practices, you understand what I meant by that. Those who get up early in the morning, these are the ones who can have a control on inhalation, but they like to exhale than inhale. And the most important step in inhalation is holding the breath. And that's exactly what they don't do. Please understand the point. The holding the breath is the most important step. I will ask all of you to do this maneuver and just let me know. When I say one, you inhale. When I say two, you exhale. Okay. Now do it for yourself to understand the physiology, what I'm trying to tell you. One, two, do with the nose. One, two, one, two. Now, when I say one and two, feel that in your tip of the nostril, you will feel the warm air that is coming out. I want you to do this to see how air gets conditioned. I want to really feel that for life. Now, when I say one, you take inhalation. When I say two, you exhale. But when you exhale, find and feel at the vestibula how warm the air comes out while a cold air goes in. Now feel the temperature. I'll make you inhale. One, two, one, two. Now, did you feel that the air that comes out is warm? Did I make you feel the function of the tract? Now you have done that. Now, if I ask you rapidly to do it, now you feel that it will not be that warm. Can we do that exercise for you? I will demonstrate the respiratory functions for you. Okay, somebody is typing, sir, in winter it is very difficult. Okay, please try. I don't know in which part of country you are, but please try this. Now do it fast. One, two, one, two, one, two. Do it rapidly and feel that it's not as warm as when you do it slowly. Please do it slowly. One, hold, two. Now you will really feel that it becomes more warm. Now tell me, when a child is having asthma, what is the respiratory rate? It's more. So cold air goes in. Now let's say I'm coming to a chronic asthmatic. I'm not even talking of acute flare-up, but there is an emphysematous chest, or I would say a fully blown up chest, and there is a shallow breathing, and there is a resting tachypnea in an asthmatic. I would say poorly controlled asthma. What happens to his airway characteristics and breathing? Now, why I'm talking this physiology? You will be feeling, sir, I'm taking inhalation daily. The question is not whether you are taking inhalation daily, how you are taking, and whether it is getting delivered. Therefore, my dear friends, different asthmatics take different times to achieve control. Did you like this concept? One of you can type L for me if I made you understand this. So therefore, don't go by the dictum that in 2 weeks, somebody should achieve the control. Somebody can achieve the control in 5 days. Somebody can achieve the control in two weeks. Somebody can achieve the control. It may take 1 month. Please have patience. Please, please keep supporting them. If it doesn't happen in a couple of days, just directly don't blame them, nor you need to revise. And my point is also that if you have started with 100 micrograms of therapy, it does not mean suddenly you should jump to 200 micrograms of therapy or add LABA just because that the child is not able to achieve what it should achieve. And I think that's the biggest point. And this is exactly what I'm coming to airway characteristics. What are the size of the aerosol particles matter? Yes, certainly it matters. The size matters not only by the characteristics of the molecule. I will tell you, for example, fluticasone is smaller than budesonide. It goes deep in. And this is as far as the drug is concerned. Beclomethasone is smallest of the particles. Now, if you take, this is as far as the drug is concerned. If you take the device, a nebulizing machine will give rise to a larger particles, whereas an MDI gives rise to smaller particles. Please understand what I'm trying to tell you. So therefore, my dear friends, when you take from an MDI with a spacer, and if you cut across and see the particles, they will be normocytic, normochromic of a smear. And if you take from a nebulizer, the particles, it will be anisopoikilocytosis. And I think that's what is the best way that I can describe for you. The way the nebulizing particles come out as a mist versus an MDI with spacer. And for long term, definitely you need a good peripheral smear, normocytic, normochromic particles that come out. Uniformly sized, small ones, tiny ones, and they will reach the distal part of the airways. Now, let me take you through airway characteristic, what happens. Can I breathe through the nose instead of the mouth? The answer is no, because large amount of the particles get impacted in the upper airways and proximal airways. This process is called as impaction. Impaction happen when the airways change their direction, like pharyngeal walls, division of the trachea, division of the bronchi, uh, divisions of the airways that wide on the crosses or in the areas where there is bronchospasm, or because of the turbulence in the airway flow, they get impacted onto the lateral wall of the airways. This process is called as impaction. It takes out almost 80 to 90% of your particles. 10 to 15% of the particles get sedimented. 1% of the particles are small and they diffuse. Did you all understand? I'll pause for 15 seconds. You need to understand this. That means if you pay for an inhaler, 90% of what you have paid goes waste. You are really paying for 10% of the inhaler. And that's enough. And mind you, the inhaled corticosteroids are 40 to 50 times more potent than the steroids like hydrocortisone that you think of. But the point is that because only 10% goes, we are lucky, and less than 1% gets diffused. Therefore, that 1% that gets diffused is the one which produces side effects. And we talk so much about it. What if 100% would have got absorbed? And what gets impacted is the one which is responsible for oropharyngeal deposition. And to minimize that, we have to use the spacer. And you may have to gargle after using the inhalation therapy. Did I make you these concepts very, very important? Now I'll come to the point of how can I improve sedimentation? If I have to improve the sedimentation, there's one mechanism that I need to do. It is to hold the breath. Now, when I'm holding the breath, all the particles get sedimented and settled. So therefore, my dear friends, holding the breath is the most important step in inhalation therapy. Now, what is happening? What is happening now is, tell me, do the adults are capable of holding the breath or the children? Adults are capable of holding the breath. Please type A if you have understood. Adults or children, A or C? It's adults. Now further, now I'm very fine. I'll come to the point. Younger children are going to hold a breath, or old children are going to hold a breath? Type Y or O. Old children are going to hold a breath. Younger they are, they can't hold the breath. Are you getting my point? Younger they are, they can't hold a breath. So therefore, we use what is called as multiple breath technique. That means they take, this is what they do in inhalation therapy. In an adult, it is single breath and hold a breath. And that's enough for them. It's not the technique. Please understand, not just the technique. It is whether you have delivered the particles that matters, and holding the breath is the most important step. That will multiply the delivery of inhaled particles by 3 or 4 times than otherwise. That means to say, I don't need to double the dose of steroids. I need to improve the technique. Did you understand this point? Somebody is not doing well on 100 micrograms. Now type and tell me, do you want to make it 200 micrograms? Or you will promote the inhalation therapy technique. You need to promote the inhalation therapy technique. I think why I am telling you the physiology and characteristics of the airways today is, please understand, you need to promote a technique. How to promote a technique? Make the child an adult. Remove all the childish behavior. What are the childish behaviors? Puffing, kidding, and can't you recollect that restless children in your office? They will not keep quiet. They will be disturbing mommy, you. They will be removing your paperweight. They'll be playing with your stethoscope. And can you remember these asthmatic kids who are restless in your clinic? Or can you recollect? Can you type yes if you can recollect? If you recollect all those kids who are this hyperactive behavior, please remember that you need to calm them down and make them settle and take them into confidence while you are explaining inhalation therapy. Why I'm talking so much about this? Because we don't realize them in practice. We feel that, sir, I have done my job. I have explained. It's for them. No, you can't. No two children are different. No two aerosols are different. No two airways are different. No two airways are similar. I'm sorry for the word. And no two parts of the airways are similar. And no to asthma inflammation is similar. So therefore, my dear friends, there are a lot of variables that affect the outcome. And I think the most important point is holding the breath. Now, this is my favorite explanation which I used to give. If you want to learn from me how to smoke cigarette, I'm Modi bhai, I'm asking your apologies, because smoking should not be promoted in webinars, but I have no other choice but to show the smoking. Because if you are a beginner as a smoker, what you will do is you will take, you will do like this. But when you are a chronic smoker, first is that you relax and you take the cigarette, you take, you hold the breath. Because if you don't hold the breath, you don't get the kick from the nicotine. I'm not a smoker, I'm telling you. I heard from others. Modi bhai, Nar, you are the smoker. But we smile. But the very point which I'm trying to tell you is that explain the mothers these common life situations. They understand. They need to understand that the inhalation has to go deep in. And this is the most important point. Now, therefore, my dear friends, where we need to reach is where sedimentation matters and diffusion doesn't matter. Even till date, I get calls from the pediatrician, sir, is it important that I should use ICS? There's real fear of ICS. It's very easy when we advise somebody to take ICS. When we want to take ICS ourselves, we think twice. That's because we have a feel that it causes addiction. We have a feel that it causes growth restriction. We feel that it interferes with the infections. We feel that this should be the last resort, not the first resort. I'm sorry, but my point is that please understand that you need to talk to them about these fears. Sir, how you do? Do I spend so much of time? Modiba is also smart. I am also smart. Many of you may be smart. Please record a video, record 1 to 2 minutes of what you want to talk and share it with them. Ask them to sit outside and come back after 5 minutes. I've done this successfully many a times. It is difficult to repeat for every patient, same blah, 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 blah. I'll take you to some other story. You will understand why we have stopped talking about promotion of breastfeeding. It takes half an hour for you to convince a mother from bottle feeding to breastfeeding. Do you agree? You have to start from hypothalamus and go up to the manufacturers of the bottle. It's not easy. You talk to somebody and next another mother walks in with bottle feeding. It's not possible to repeat again. And same thing happens with inhalation therapy. Same thing happens with vaccines. And I'll tell you, pediatricians, we have been tired of explaining. Our enthusiasm will definitely change with time, with number of patients that we see, whether it's the first or the last patient. My dear friends, I would request all of you, please, 2 minutes of video, 5 minutes of video of your own. Please record on your smartphone what you want to tell. The best one, record and share. No, it's so easy. Your receptionist can show them if they don't have a smartphone and they can understand everything. Later, let them walk in. It is easy to explain to them after their parts of the doubts are cleared. Please do this. And that's why I think you myths about inhalation therapy have to be clear. You need to weigh the risk of benefit versus risk when you want to give inhalation corticosteroids. Remember, I'm telling you, I'm sorry for repetition after so many years, but still this is a matter. We use small doses and small doses are effective. 100 microgram with a better technique is effective. 100 microgram with formoterol is good. 200 microgram without formoterol, we are not even recommending. Please understand. And if somebody is using 200 micrograms, I will tell you, you are a bad pediatrician. If you are using 100 micrograms, then you are a smart pediatrician. If you are not able to manage with 100 micrograms, that means to say, probably it's not the fault of the asthma, it's the fault of the pediatrician. I'm sorry. Because when I get the statistics in the best journals that 99% of the asthmatics don't follow the treatment, why 1% would require 200 micrograms, 400 micrograms? I think you are enough if you don't follow all the GINA guidelines. Only look at the step 1 and don't even look at the step 2. I have hardly used step 2, step 3, step 4, step 5. The first couple of steps in the stepwise treatment of asthma is more than enough for most of you. Now, somebody is asking me why the parents prefer nebulization. I will definitely answer to you. Don't worry. Now, a question, sir, I take steroids is going to modify the disease of asthma. Long back, we have proved that the the asthma disease modifying effect of steroids is a myth. We thought that if you take inhalation therapy with steroids, you are done. No, it is not disease modifying, it is disease controlling. Therefore, we used to use the word preventers. Now we are using the word controllers. Now, if you look at the pharmacokinetics and dynamics, lipophilic property is more with cyclosinide and fluticasone. Protein binding is little less with beclomethasone and budesonide. Systemic clearance is less obviously with fluticasone simply because more of it is protein binding. And particle size, beclo is very small, then budesonide is little larger and fluticasone is little smaller. Why I'm trying to talk all these factors is if you're too much into, if you want to do PhD on aerosols, you need to go for it. But it's just like discussing about whether in a cricket, white ball cricket is good, red ball is better, test cricket is better. If you're a good batsman, it doesn't matter whether you're playing T20, whether you're playing test match, whether you're playing white ball, whether you're playing in the night or day. I think I've explained to you what it means. But does it matter winning a toss or choosing a red ball versus white ball? Yes. If you're both of them are good batsmen, then definitely whether somebody is good on, and same thing with tennis, for example, grass one or otherwise. So my dear friends, please understand the point that these characteristics matter. Take care of them when you want to step up the therapy. See, somebody may do well on fluticasone, somebody may do well on budesonide, we never know. Or for that matter, beclomethasone as well in an adult. So don't worry about it, but the choice of steroid doesn't matter much, but use an inhalation steroid. Now, is it challenging? My question is, I will ask you, please accept boldly. How many of you till date do not know the correct technique? Please be free. Huh? I'm not going to take down anybody's name here. Sir, till date, I don't feel that I'm perfect. You can say, you can confess. You type C if you want to confess. Sir, I understand that we are not very perfect. Do you all agree? And I'll tell you, don't feel guilty why you are not perfect. I'll give a simile to you. Please understand. All of us know driving, correct? Car driving. How many of our perfect drivers, perfect gear change, somebody is not shaking, everything going smoothly on the road, have a perfect mileage, save the diesel or the petrol. Are you getting my point? It's not possible. This learning curve of technique is lifelong for everyone, including pediatricians. If you have understood, you will explain to the mother. You will explain 80% of what you have understood. And if your understanding is 60%, the mother gets only 30% of the message. Is could this be a reason for failure? Answer is yes. Don't feel bad. I will show you in the next session my videos of 2010, 2023, 2016, 206, and I will show you with dates. Even I have uploaded on the social medias. My videos are wrong, some of them. If you find faults in my video and get back to me, I'm the happiest person. I'll give you Bharata Ratna with Modi's permission. Because Modi Bhai only can give Bharata Ratna for you. Please understand the point. What I'm trying to tell you is that the correct technique is a lifelong learning, and you will improvise year after years and years of practice, and you will know what exactly to tell. But my point is that promote laminar flow, promote a quiet respiration. Breath holding is the key. Encourage them. Have a good posture. Have full chest expansion. And the child is not anxious or apprehensive. Promote deep breathing instead of shallow breathing. And I think all these were well demonstrated in that smoking example. That's why I love that example, only because whatever qualifiers I have told you is there in a good smoker. Because over, do you think smoking is learned on a day? It's done over years, isn't it? So that's why they master. And you can't just say that it is possible. And who should teach the technique? My dear friends, please train your receptionist. You can't teach. I'm telling you, I have failed. You can't go on explaining to every patient. It's very, very difficult. My dear friends, you need to train the second line. If you don't train the second line in busy OPDs, you will lose asthmatics. How to train the second line? Give them the videos. In your TVs outside your clinics, instead of putting news channels, you put videos of yours to teach the technique. They will see. If you want to learn the proper techniques, my videos are there in YouTube. Google it, inhalation therapy, etc. You will get. You can also make yours. You need to identify the mistakes. And how to identify the mistake? When they do on real time with you, in front of you in your clinic, you can't make out the correct or wrong technique, my dear friends. And I'm telling you why. That's because when you see an LBW or a caught behind a wicket in a match, you can't make out. But when the replay, you say, yeah, it is LBW. It was out. Do you all agree on this point? Therefore, my dear friends, if you make video of a patient and watch the video slowly, you will definitely be able to point out the mistake. And every time the patient will have at least 2 or 3 mistakes that needs to be corrected. And it requires 3 visits for a parent to learn at least good enough technique of inhalation. In the first visit, everything is not possible. Please don't try to push everything in the first visit. Be slow and you tell them that there's something. You learn these two and come back to me. I'll teach you next time. Now, if you think that receptionist can explain a bit of it and you can fine tune, then I think then also I'm done because the receptionist need not explain perfect technique. Did you understand my point? She can tell you, okay, chin up, hold, you have to shake, you have to hold breath. Let them teach at least 6 to 7 steps. And when they learn that much, when they come to you, uh, you can explain better. So identifying and correcting the poor technique is the most important step. Every time, don't tell them, yeah, this boy now is a headache boy. He won't learn the technique. These type of things should be avoided, my dear friends. Improve compliance and encourage them. There are challenges because of overuse of beta 2 agonists. They don't find relief with ICS. When they use steroids, they don't get relief. So therefore, they will not know whether their technique was correct or not. Are you getting my point? If you were to use beta 2, you will know whether your technique is correct or not. Narendra Singh, I'm going to explain you the right technique. Don't worry. We're going to have 3 or 4 sessions on inhalation therapy. I felt this is the most important sessions that we need to take. In all this session and subsequent sessions, I will teach you the correct technique. You don't worry. You need to attend all 3 or 4 sessions that I will take this over a period of time. Now I got another 10 or 15 minutes. Let me cover as much as possible. We need to avoid overuse of beta 2 agonist. But why I'm coming to that point is when you are on inhalation steroids only, the problem is that the effect comes late. 2 or 3 weeks after use of ICS, you will know the effect or relief. In that case, there is a problem unless you use a combination. If you observe, beta 2 users are more than that of steroids. How do you choose a device? I have just typed 3 or 4 devices for you. There are many devices. You can choose any one of them. The most important point is you should choose MDI while the parents choose nebulizers. DPI, somehow personally, if you ask me, DPI are very good. That's because if you say MDI versus DPI, you tell me in which the patient is most active. Can you have a passive user and a DPI? No. The patient participation, if you take, is more with the DPI than with MDI. Do you agree? Type agree if you agree. DPI versus PMDI. I'm coming to that. They participate, they have to participate. They have to do. It's not in an MDI, they can be relatively passive. Therefore, when you agree, the point is that you should try to move them from MDI to DPI, and DPI is better in an adult, whereas in children, we accept MDI. So can I take a message from all of you? PMDI spacer is okay for a child. For an adolescent, can I prescribe DPI? Did you understand how to choose a device? And for an infant, it's okay to accept a nebulizer because it could be one episode of bronchiolitis, but not asthma, and it's all right. Are you getting the point of a spectrum of the age versus the device that you will choose? Now, there was a beautiful question from one of the audience that why the parents want nebulizer but not inhaler. Please read these lines very clearly. MDI, there is no preparation required. It is ready to use. You have to just shake, keep, and start using. Now, who will prepare? It is the parents who prepare. Who will inhale? It is the child who inhales. Listen to me these 2 words. Preparation is by parents. Inhalation is by the child. Now, the parental difficulty is very, very, very less in an MDI. Child's difficulty is more in an inhaler. Contrary, for a nebulizer, too much of preparation is required. You have to open the box, put the fuel, switch on, but everything. But it's easy to inhale. Did you understand the contrast? Parents don't mind taking more pains, but they want the child to be comfortable. They don't want the child to do more. I'm giving the examples of all parents who do the homework of their children. They don't mind taking pains, whether the child learns or not. Are you understanding the point? Therefore, parents prefer nebulizers and they want a child to quietly inhale and they don't take efforts. Do you agree on this point? I asked at least 10 to 15 mothers who were using the nebulizers before I prepared this slide. It is definitely true. And it's also that they don't use steroids in the nebulizer, they use the bronchodilator. So they see the effect and they're very happy. And the biggest problem is that they use in colds, which are not asthma. And when you say asthma, they just quickly revert to the nebulizers. And that's exactly is the problem with the nebulizers. Previously, they were available on prescription. Now they are available on promotion. Now it is already the word of mouth with most of the patients. And so it is difficult. And the difficulty is that the delivery from the nebulizer is less. And therefore, it is that you have to put more drug in the nebulizer because only 1% is delivered. From an MDI, 10% is delivered. So you waste lot of drug and therefore you pay more. You pay more for a respule than for an inhaler. Do the device matter? Yes, there are n number of articles. Don't worry about taking down. I'll share this PDF to all of you. You can WhatsApp to me on my number and I will share you all these slides. So you can refer to all these articles, which I'm going to share with you, and you can read them for further reference that the device certainly matters. MDI with spacers are as effective as nebulizers, irrespective of the age, but surprisingly, children don't follow both of them. Okay. Now, do we need to shake? Why we need to shake? It is because the canister in an MDI contains propellant and a drug and some surfactant like material. You need to mix well. It is like your bale. You know, you remember the bale or pani puri, that masal puri that you make. You need to mix well. It's like you are on the tawa or in cooking. You remember, you nicely shake. If you don't shake, it's not good. Why? What is there in the canister is not a solution, but a suspension. Did you like this sentence? You type L for me because with lot of pains, I made this slide. It's a suspension, not solution. I'll give the examples of two commercial products. Osteocalcium is a suspension and Calcimax or Shellcal is a solution. So if you remember some of the syrups and medicines which are suspensions, that sediment at the bottom, because it is a suspension, you need to shake. So how much to shake? At least shake well, and then don't start. Shake well. You don't worry if you shake more, nothing is going to happen. And I can't tell you. If you vigorously shake, then one or two are enough. If you're slow like this and all, then you may have to do more number of times. You understand? You just need to mix well the drug and the propellant. And I can't give you guidelines, and I think none of us can prepare a guideline. Shake 4 times, shake at least 4 to 6 times. I don't think we can give any guidance for you, but remember that you need to shake well. And when you shake well, it is ready. And when you press, the aerosols are going to come out. Look at the particles. They are larger. When they move further, they they are going to break into smaller and smaller particles by law of physics. When you give a blast, the particles are going to become smaller, 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 and finally form a mist. You remember the bomb blast, then you will understand what I meant by the particles. Further you go, they become smaller and smaller. And therefore, my dear friends, if you want uniformly sized particles, should the MDI be closer to your mouth or away from the mouth? Let me say you don't use a spacer. Should the MDI be closer to your mouth or away from the mouth? If you want the particles to be uniformly sized. Closer to your mouth? No. If you hold closer to your mouth, you get larger particles. If you hold away from the mouth, you get uniform particles. Did you understand the point? If you want to hold away from your mouth, you need some conduit in between. So spacer is the space between an MDI and the mouth. Now, did you understand why do you need? It's 13 centimeter is the ideal distance that allows the particles to become smaller and uniform. Please understand the point. And therefore, you need a spacer, not just because you want to hold all the mist. Spacer is not just a holding chamber. It's a chamber that makes your particles smaller and fine. So the particles break, the particles become smaller, the particles become uniformly distributed, particles form mist, and particles get reduced in velocity. They are at 100 kilometers per hour, 60 to 100 kilometers per hour. When jet comes, they become 0 kilometers per hour when you use a spacer. Did you understand? Now type and tell me whether you need a spacer for an adult or not. For an adult, will you prescribe a spacer? Yes. Yes. Don't say, I'm an adult and therefore I can take an inhaler. You may be very good in synchronizing inhalation, but the size of the particles will never become small. Please understand, therefore, you need a spacer. This is the size of the particles by molecules. Remember, this is DPI of fluticasone is the largest one. Budesonide DPI is larger and it becomes smaller and smaller with beclomethasone and cyclosinide. And uh, fluticasone MDI is good enough. And I've shown you the 5 micron size there. Please focus on that. That's 5 to 10 microns is medium to small airways, my dear friends. And therefore, all particles are okay for me. Don't worry about size of the particles. It doesn't matter much. It's just the question of one pharma versus another pharma or one drug versus another. If you want to debate, but generally it is the adherence and the technique that matters. That's important. Now, do I need to let out 4 to 5 puffs when I use first time? There is some amount of clogging that happens. I don't know. Have you used the inhaler? And when you press first time, not a good one comes out. Can you type? Is it true? I have experienced this. When I ask the pharma people, they say, "Sir, okay, you can start from the first one." But I feel somehow you take anything. You can take your deodorant sprays. You can take your shaving creams or anything that works by the mechanism of pressing. The first puff is not very good. I don't know. Even toothpaste, first time when you squeeze doesn't come out well. And when you press again, it comes out well. And I think this is just simple maths that one need to understand. 1 or 2 puffs, you can let it out and you can use it for priming a spacer. Therefore, my dear friends, what goes waste, let it get into spacer for priming. Priming is not that required scientifically nowadays with the static and a nice reflecting inner wall that it is made up of. But I'll tell you, instead of wasting 1 or 2 puffs in air, it is better to let first 1 or 2 puffs in the spacer. Can we all take it as a take home message for all of us? It's pretty simple. Why to waste in the air? First puff, you put it in the spacer. So it is pretty simple. And 1 or 2 puffs will get into the spacer. That's good enough for you. Or 4 to 5 puffs also you can see. And the spacer is now ready for use. Do we need to put a cap for an MDI? Yes, because the dust, etc., is going to clog the nozzle and it's not for any problem, but just to prevent the dust from clogging the nozzle. So therefore, you need to put the cap and you have to remove the cap when you have to use. And I have nicely explained to you why you need a spacer. Now I'll come to the question, which spacer is ideal? Any spacer is okay. That is simply because it's, I think, please understand that it is not the shape of the spacer, volume of the spacer that matters. Volume of the spacer is a function of number of times that you breathe, but it's the distance from the mouthpiece to the end that matters a lot. You must allow it to be. So you are getting chinnu spacer, that small ones. Like some people ask me, sir, can I use them? Nonsense. Please don't use them. Okay. So people are asking, can we use Bisleri bottle? Answer is no, because Bisleri bottle is also expensive. If you just pay 6 times that of Bisleri bottle, you will get a spacer only. Why static and non-static? The I don't know if you all remember your days of physics. If you use a dry hair and comb and piece of paper, you have a static. I mean, paper pieces get attracted. Do you remember that experiment of physics, all of you? So that is what I meant by static charges. And these uh, um, PMDI are filled with negatively charged aerosols. Please remember, the propellant, not the drug, is negatively charged. And when it comes out, the inner surface of the stat is negatively charged. And therefore, it repels. That's what we meant by static charges. Did you understand? So, zero stat means that it is negatively charged repelling body, so that lot of the aerosols form a mist, not smearing to the wall, inner wall of the spacer. Lot of it is available. So this is important for you to understand. But remember, it is not one company which has the name of zero stat is um, non-static. All other companies are also non-static. Nowadays, we don't have static spacers available. Previous polyamide spacers, polycarbonate spacers, or the white wallas which we are using, they are all fine. Now, all these transparent spacers, modern ones which are available, are good enough. Now, for poor patients, please prescribe a spacer. Somebody is asking, can I prescribe something for poor patients? Poor patients will save by controlling asthma by using a good spacer. If you ask me, do you want to invest on the inhaler or the spacer? I will invest on the spacer. Now tell me, is the toothpaste important or the toothbrush is important? If those of you who think toothbrush is important, spacer is important. It's not the paste that is important. How do you brush? Lastly it is the brush, then the paste, and it is the technique of brushing, than the brush. I think I explained you very well how one is important over the other. DPI versus MDI spacer. Wonderful question. I think MDI with spacer for younger children, DPI for adolescents. That's a simple thing. If you ask me 10 years, if he's fine with DPI, fine. Only drawback of the DPI is that the number of the doses is 15 or 30 that's available, and but with an MDI, it has 200-meter doses, and therefore they will use it for longer. At least they will take around 2 months of therapy, whereas with the DPI they have to buy every 15 days. And you know our patients, they don't go to medical shops frequently, and therefore they may not buy. Only disadvantage of the DPI which I found in my practice. Can I share my real life experiences? I can't tell you from evidence-based medicine, I'm sorry. But DPI patients have to go to medical shops frequently than an MDI patient. That's what I meant by that. So therefore, it is easy for us to understand that what about synchro breathe? I will talk about synchro breathe next time, because synchro breathe is hybrid between DPI and NMDI. And I'll explain to everyone, don't worry. How small children can be made to hold a breath. It is impossible for the small children to hold a breath. And therefore, my dear friends, Dr. Parthasarathi is asking, so therefore it is impossible for them to hold a breath. Therefore, we tell them to have multiple breath technique. Is what small children will do, old children will hold a breath. Generally, children above 5 or 6 years of age can hold a breath, whereas the younger ones, if you teach them, some of them can hold a breath. So I will tell you all the questions will be answered. Maybe I will uh, explain to you again and again. Now, I think I have made you understand why you need a spacer, because you need to break up, you need to form the mist, you need to decelerate. Now, this is the deposition that happens in static versus non-static. So if you have more deposition in the spacer, less is deposited in the lung. Whereas if you have less deposition in the spacer, more of it goes to the lung. Now, priming of the spaces, it's a beautiful article. Anyway, I'm going to share with you. It's published in Thorax 2017. Uh, if you don't prime, then it may result in little bit of inconsistent delivery, and therefore it's better to. Which should be the size and shape of the spacer? I've got for those of you who are distillery lovers, you can use them, and I think it's better to find some social groups who can sponsor spaces. You can meet Lions Club, Rotary Club, some charitable organizations in your place. If you feel that, please, they want to donate something, ask them to donate spacers. No, inhalers, let the patients buy. And I tell you, you can buy a spacer and sell it for your cost price, which I have done many times. There is a small difference between cost price and chemist price. If you feel that somebody is poor, please give them at cost price. Take out the chemist margin. The representative can give you around 10 or 15 spaces for personal purchase. You can do various ways of innovation, but don't compromise on the spacer. That's a point which I was trying to tell you. Innovations are very important. I showed you some of the spaces which are not good. I have got a comment on one company that produces this um, a half puff kit, but I wish that they won't put a case on me. But the point is that in that kit, there is a mask and there is a spacer. And have you seen the size of the mask? It's a big mask. What is the age? Can you type what is the age for which the mask of the half puff kit fits properly to the nose and to the mouth? You have seen the half puff kit? There is a big mask. And the size of the mask of the hub puff kit fits into 2 year, 3 year, or 5 year. It's almost 5 years, not for 2 year old. Did you understand? For a 2 year old, it will look like this. You understand the point? Now tell me, for somebody of 5 years, do you need a mask or can you take directly from the spacer? You don't need a mask. Did you understand how irrelevant and irrational is a company make? A good company. Therefore, I have passed these comments to the company also to stop that. But they are very happy with this because sales are good and our own people prescribe. So therefore, my dear friends, assemble the mask and the spacer separately. Mask is for the face. Mask is for the face, while the spacer is for the lungs. Did you understand? Mask is for the face, while the spacer is for the lung. You can have a small mask and a big spacer. You can have a small mask and a small spacer. You can have a small mask or a medium mask and a medium spacer. It's all yours. Please choose them properly because there are different types of children. And if I want to tell you, you can have a Down's child, you can have a Perry-Robin syndrome, you can have a congenital heart disease child, which would require an inhalation therapy. And faces could be different. Please look at the face of the child, not just the age when you want to prescribe the device. Did you like this sentence? We don't look at the face. Please look at the face of the child also. We say he's an infant, and in any infantile mask would fit him. Please look at the face. Please look at the shape. Look at what fits in. It's not just that something is ready made for you. Please, you are a beautiful engineer who would even devise and plan a perfect match of the spacer and a mask for the child. Now, if I use a larger spacer for the given child age, then I have to breathe more number of times. If you use a smaller spacer in one breath, you can empty everything. Generally, 4 times the tidal volume of the child should be the volume of the spacer. I'm sorry for this thumb rule. What I meant was, if you have tidal volume of 100 ml, you need a 400 ml spacer. If you have a tidal volume of 75, then you need 300 ml spacer, which are available. And 75 ml is the tidal volume of most of the children between 1 to 5 years of age. Am I done with that? So therefore, I think that infant, child, and an adolescent is okay for small, medium, and large spacers. This is very, very important. Now, I think please decide if you need a mask or no mask. Generally, about 2 years of age, you don't need a mask. 3 years and above, definitely you don't need a mask. Between 2 to 3 years, you decide. Some children are smart. If they can get away from the mask, it is good. If they can't get away from the mask, please prescribe. It depends on the smartness of the child, and you should really see and decide. Suppose you have prescribed a mask and and a spacer, and the child grows. Or I have done this also, Madiba, in my practice. I had prescribed a spacer and a mask for the child. It was 2.5 year old, and the child learned. Afterwards, I removed the mask. The child continued with only mouthpiece. What I meant was, initially they may need a mask, but in subsequent visits, you can take out the mask. Are you understanding? You can improvise the delivery. It is not just the age that matters, my dear friends. It is how you are going to teach the child, how you can make the child more and more active. The mask makes your inhalation passive. A pipe or a mouthpiece makes it active. Mask means, correct? And tell me, in a mask versus mouthpiece, in the mask you have nasal breathing. In the mouthpiece, it is not called nose piece, it's called mouthpiece. There's only breathing to the mouth. Orotracheal inhalation is better than nasotracheal inhalation. And nasotracheal is just 50% of orotracheal. That's why you don't put the cigarette in the nose. You put the cigarette in the mouth because you inhale properly. So although the mouth is used for eating and nose for breathing, you need a nasal breathing to humidify and warm, not to inhale. God has given us the nose for humidification purposes, for filtering purposes. Here you are not supposed to filter, you are supposed to enter. And therefore, oral inhalation is better than nasal inhalation, my dear friends, given a choice. And mask makes it inferior, mask makes it passive. Further, mask adds to the dead space. What I said, the distance between your teeth and the mouthpiece is 13 centimeter, and the mask will add another 3 centimeter. It will make it 16 to 17 centimeter away. So you are farther away. There is more dead space, and therefore your inhalation becomes lesser and lesser. So I think I am getting into too much of mathematics of inhalation therapy, and I can see smile on Modi Bhai's face. It is too much of engineering that is not required. All you need is a house. Don't worry about thickness of the wall, size of the door, size of the window. But I'm discussing everything for you to understand how beautifully you can customize and craft your inhalation therapy. And if your patient understands that you know all these things, they like you very much. And maybe they are motivated to take inhalation therapy. Use correct steps. You need to shake, you need to fix. The patient has to breathe 1 or 2 times to make him understand. He has to exhale, then you put it in. He has to inhale. Don't make it turbulent. Don't make him anxious. Press. This is wrong pressing. Press with properly two fingers, not with thumb. Thumb pressing is bad. I don't know. This is taken from leaflets of the pharma, and they have also given it wrong. Thumb pressing is not bad, but your thumb should be stronger than 2 fingers. I don't think so, which is possible. The problems are mistakes. These are all the mistakes. I'm going to cover them in the next sessions. I'm going to go fast now just to see that the mistakes that are done. One study showed that lot of them, they exhale deeply, but they don't inhale well. That means he's done well, you understand, children try to exhale well and they don't hold breath. This was a beautiful study of correctness and incorrect. I'm going to share all the slides to you, so don't worry. You can go to this article and see. Lastly, let me come to nebulizers, and I'm going to discuss less about nebulizers, only to tell you jet nebulizers are jet fountains, whereas sonic nebulizers are smart and they give smaller particles. And jet nebulizers are widely used, whereas sonic nebulizers should have been widely used. And lung deposition makes huge difference in children. And the mask, I've shown you how the masks makes, and a loose fitting mask of puff kit will make everything that comes around the mouth, and nebulizers should be used properly, and we don't do them. Lung functions uses with the mouthpiece than the mask. With the mouthpiece, it is 2 times better than with the mask. In the same patient, inhaling through the mouth is important than through the nose. And this is which is safer. So the safer one is mouthpiece than the mask. My dear friends, even the particles can go to eyes if it is not well fitting mask, and their mucous membranes can be absorbed. So these are all small things. These are the steps of nebulization, and I don't want to teach you too much on this. Please remember, should I go for continuous versus intermittent nebulization? Both are same. Nebulizers needs to be maintained. You have to use them correctly, clean correctly. The spacers are most important than nebulizers, and for chronic treatment, nebulizers are not good. This gives you beautifully the comparison of budesonide inhaler versus respute. You have to, if you maintain an asthmatic on a nebulizer, you have to send 60 rupees per day for the same effect, for which you have to spend 5.7 rupees per day if you use an inhaler. It is not just because of technique, even because of saving money. And it's cost effective as well. It is scientific also. It's good also. So nebulizer should be second or last choice and should remain so for the reasons. And somehow I'm passionate to DPI. And in the subsequent classes, I will tell you, you need to use the correct steps for DPI. And in the DPI, you have to exhale before inhale. In the MDI, remember only one step. Holding the breath is the most important step. In a DPI, the most common mistake I've seen is they start, but you have to exhale and then inhale. If you don't empty the lungs, you can't inhale well in a DPI. That's the most important step. Rest all steps everybody does. In my practice, I have seen that they upfront start. They don't exhale before inhaling from a DPI. That's an important step for me. These are the studies with regard to some articles on nebulization and length of stay, which I'm going to discuss in subsequent things. This is just a slide on proof. Don't worry too much about it. I'm going to discuss next time. Aerosol deposition patterns depend on the age. As the age advances, they inhale better. And from an MDI with spacer, 12% is deposited when they're around 10 years. Whereas even in the modules you have read, but 2 to 6 years, only 5% is deposited. Infants, 1 to 2% is deposited, my friends. Then that means to say, an MDI, don't say it delivers 15% is better in an infant. An MDI in 1 to 2-year-old is as good as a nebulizer. Did you understand the point? So if you compare device to device, scientifically, we should promote MDI and therefore we say that's better. My dear friends, you always, I'll tell you, even though you feel that 1%, 2%, sir, is it enough? In fact, per kilo body weight, what goes in a child is better than that of an adult compared to surface area. I think pediatric dosing versus adult dosing. Did you understand the concept? You need to understand that. Please explain them that local delivery is important. This is the last slide for me. And I'm going to tell you, you need a targeted delivery and more incorrect a technique, more, more number of mistakes they do, asthma control is worse and worse. This is exactly is the study which I'm going to publish to you. This is the last slide of mine because I'm going to continue in the next session. You look at the lung delivery in a DPI, MDI, MDI with spacer, nebulizer. Did you understand DPI and MDI spacers are excellent for lung delivery? Next, for oropharyngeal deposition, only MDI more with a spacer, it's reduced. And with a nebulizer, lot of oropharyngeal deposition. Can you tell me why? Large particles. I said anisopoikilocytosis. My dear friends, apparatus, apparatus deposition is more with the spacer. Do priming, use zero stat. Don't use Bisleri bottle because lot of drugs get wasted in the apparatus itself for a nebulizer. Less is there in the apparatus. All comes out of the apparatus and gets into the room. It is not in the lungs, not in the apparatus, but in the air, in a nebulizer, my dear friends. Lastly, what comes, it gets exhaled is less with the DPI. Lot of it gets inhaled. DPI is all about inhalation. There is no exhalation in a DPI. But in an MDI, bit of it comes in exhalation. Whereas from a nebulizer, lot gets exhaled. And I think, please understand that all of us recommend MDI with spacer because even in smaller ages, it's very good. And will meet you very shortly with part 2 of inhalation therapy. When it comes to next time, I'm going to stop sharing. I try to answer as many questions as possible, but I will share again. And please type and send to me what is the topic that you want next time. And for some of you, I have shared you. If you have not joined respiratory tract infection course, you can log in. I have shared you the link. You can join. Even now, in a couple of days, I'm going to freeze the admissions, 2 batches. Both the batches are getting filled. So, my dear friends, please fill faster and you can send me your remarks. I'm going to share completely all the slides. I will send my WhatsApp number to you. Please send me the message and I'm going to share you all my slides, whatever you want. You can even reproduce without my permission anywhere in the world. I have no copyrights because I have also copied from somewhere. But what I'm talking is not copied from somewhere. The slides are from somewhere. They are all available. But what we explain is most important, and what we understand and how it matters to a patient is more important than the content of it. I think the way I have explained to is more important. We will all share with you slides. I don't take much time, but I will tell you, I will leave it to Modi for a couple of comments. I'm sorry, Modi, I made you wait for 1 to 1.5 hours. These sessions are always repetition for you. Kindly accept my apologies because I feel that audience who are listening to us very, very important for us.
Thank you,
Modi,
dear.
my words from you.
Thank you, dear Subramaniam sir. And dear delegates, must have been music to ears for all of you. This inhalation therapy, part 1. Now, the floor is open for all your queries to be answered by Subbu Bhai. A clarinet, can they just unmute themselves and ask directly without putting up a question at the chat box?
Anybody wants to ask question can raise hands. I can allow them you inside.
Yeah.
No problem. And another 5 minutes. Please
Shreyasi.
raise your hands. Dr. Kanu, Dr. Narendra Singh. I'm adding all of you. You can ask questions.
Dr. Narendra, kindly unmute and ask.
Whosoever wants to ask, you can ask. And those of you, some of the questions, if they are not answered, don't worry. I'm going to answer. This is not first, it's just a first session. You're going to have more and more in another 3 or 4 sessions. So don't worry about it. We are going to again repeat the
Miss
sessions for you.
Shreyasi, can they unmute themselves and ask questions?
If you want, you can ask questions. If you're fine,
Yes, sir, they can.
So, Dr. Narendra Singh,
Please unmute yourself.
yeah,
mute
will
and
you
ask
please
questions.
unmute and ask Dr. Narendra Singh? Kindly unmute.
I'll share all the videos next time. I have 20 to 25 videos. I used to take around 10, 15 videos. I've added another 10 videos for you. Next time I'll discuss every videos for you.
Okay, Dr.
And on the
Durge.
videos, we'll have questions.
Good day, sir.
Yeah, please. Thank you.
Sir, Dr. Amrita here, Dr. Subramanian, sir.
Please, ma'am.
Yeah. Sir, I missed the initial part of the session, but
Oh,
in this later part, when you recommended that, say, 2 to 3 years and ahead, we may encourage letting go of the mask, but continue to use the spacer. So, my question is to you, sir, if the child is not closing the mouth over the spacer very well, I mean, wouldn't that cause again an inefficient inhalation and subsequent inefficient use of the MDI?
Good question. The closure of the mouth is not required. That is simply because the problem is, when you inhale, there is a negative pressure in the thorax. It goes in. If you don't close your tight seal, the lip, you may also inhale air along with the inhalation. Correct? No. If you're not tightly sealing,
Right.
you may inhale a bit of air. So aerosol mixture can go. That's fine for me. But the point is that you need to empty everything in the spacer. You may need one breath extra. But if you tightly seal properly and inhale, that means to say you can empty the spacer.
Spacer quickly.
Let me tell you, generally, if you have 150 ml of tidal volume and the spacer volume is 1 liter, you need 150 into 6, 9 breaths to complete everything in the spacer. Okay, I'll repeat. If you have
Right.
100 tidal volume and the volume of the spacer is 750 ml, you need 7 to 8 breaths complete. Did you understand? Inhale completely. So
Yes, yes,
therefore, I don't want to use 750 ml for a child with tidal volume of 100. I will use 350 ml spacer and 4 breaths. That is because if you see the child's involvement, they will take 4 or 5 times. Uncle, they will do 4 times. If you tell him, I will show you how he does 10 times. That
right.
means fourth, fifth, and onwards, his involvement gets reduced. Children's attention span is less. So finish everything in 3 or 4 breaths. Therefore, I'm asking you to prescribe 4 times the tidal volume, round it up, and the nearest available volume of the spacer you should use. Am I clear to you?
Okay, sir. Understood about the choice of the size of spacer, and thank you for explaining that a complete closure of mouth is not very
No,
good.
not a must, but I mean to say you have a valved spacer, isn't it? If you exhale, anyway, it goes out. And if you inhale, the valve opens. It is only when you have too young child and you can't open the valve, then it may breathe from the mouth due to non-proper closure. That's too theoretical a discussion, I think.
Okay,
Doesn't
okay,
matter
sir. Got
much.
it. Thank you.
Dr. Abhinay, please.
Good day, sir. Hello.
Yeah,
Please tell
please.
me.
Able to hear me, sir?
Yeah, yeah.
Sir, in a young child where we use MDI with spacer, so we should advise them to do mouth breathing, is it, sir?
Huh. When you are using a spacer, you should not breathe through the nose.
Spacer with mask in a young child, less than 2
No,
years
when
old.
you use the mask. Okay. Now I will give an exercise to you, Abhinaya, you will understand.
Okay, sir.
When you want to inhale from outside, when you open the mouth, you can't inhale through the nose. You try opening your nose and mouth and try to take a breath. All of you who are watching, can you inhale both from the nose and the mouth?
No,
No. When you
yes,
open the mouth, you only inhale from the
through
mouth.
the mouth.
Mouth. Only when you close the mouth, you inhale from the nose. Are you
Oh,
getting my point? When you
yes,
both
sir.
are open, I don't think you can inhale from the nose. Even there was study from Jodhpur, Dr. Jagdish Prasad Goyal, who was referring to me. They've done a study. Even I was not knowing this. When I was a faculty, went to advanced asthma course, I learned from Jagdish Prasad Goyal. I'm naming him so that he's my dear friend, and I acknowledge the beautiful knowledge he gave us in that forum when he told that simultaneously you can't take both from the nose and the mouth. You can take from the mouth, but not from the nose.
So what we should advise the parents, sir? What we should advise the
Parent
child?
is simple. Focus on the mouthpiece. That's the best advice. If you can't afford a mouthpiece, then you go for the mask.
No, in a child younger than 2 or 3 years of age,
Then
where
fine.
mask is a
Then you
must.
don't have a choice.
Yes,
See,
sir.
you go for passive. And I will tell you how that works. I'll give an
Okay,
example. You use 100 micrograms for a 4-year-old.
okay, sir.
You use 100 microgram for a 2-year-old. Same dose. Are you using 50 microgram? No, no. You are using 100
Yes,
micron.
sir. 100
Now tell
micron.
me, for the tidal volume, what is delivered in a 2-year-old is more. Are you
Okay.
getting my point?
Yes, sir.
Now, therefore, children adjust their inhalation doses based on their tidal volume and effort, they are rather than the volume of spacer.
Okay, sir.
Are you getting my point?
Yes, sir.
God has given beautiful lungs and volumes because of which the doses they require, they themselves titrate.
Okay, sir.
Therefore, if there is a faulty technique, there is more dose that the child inhales in a 2-year-old compared to 4-year-old. So it makes up for it.
Okay, sir.
Are you getting the point? I don't
Okay, sir. I'm able to
know
understand it,
whether
sir.
I delivered a message for you.
Yes, sir.
Dr.
I'm able to
Chinmay,
get it.
This is
Thank you, sir.
all, mind you, I can tell you, Modi bhai can tell Subbu bhai, don't discuss all this because this is too much of physics, too much of micromechanics, which I'm discussing. But largely what matters is, I think it is whether you take. We are discussing whether it is 20 milligram per kg, 30 milligram per kg, 40 milligram per kg, or 60 milligram per kg of amoxicillin. But whether you take amoxicillin or not, whether you complete the course is more important than the dose,
Rose.
whether it is tablet, capsule, or syrup. Am I giving you some good analogy for you?
Yes, sir. Yes, sir. I'm able to understand, sir.
Yeah,
Thank you, sir.
please. Anybody else?
Dr. Chinmay,
Yes, sir.
Please ask.
Uh, Nowadays, nebulizer is commonly accepted by Indian people, sir. Is it advisable to give oxygen with every time nebulization? Suppose I'm a general pediatrician. I'm practicing in my private clinic, and I'm
Please, I
prescribing
would
nebulizer at
say,
home.
I would say use oxygen even if you don't require. I'll tell you why. At least they will not use the nebulizer on their own. They will feel that I have got a nebulizer, but I don't have the oxygen. And I'll tell you, most of the times, whenever you require a nebulizer, not an MDI, there is a situation where oxygen is also indicated. Can I tell you in one short line? I'm going to explain you in the better in the next time. Indications for nebulizer and indications for oxygen in acute asthma are same.
No, sir.
When you require a
My
nebulizer, you
question,
require an oxygen. And
my
when you
question
require
is,
an oxygen, often you
in
require a nebulizer, you can't manage with MDI alone.
No, sir. My question is in day-to-day practice,
Hmm.
the acceptance of the nebulization is lot more in Indian people. What used to be, it's no 10 years back. It's a
Correct.
quite acceptance in Indian people कि sir हमें गैस दे दो.
Now they are
Uh,
accepting. That's true.
they're
Chinmay,
accepting. They're accepting. But
Subbu
That,
bhai,
it
please. Subbu
is it
bhai,
advisable to give nebulization at
no, no,
home?
no. When they're accepting, why you want to give a nebulizer? Don't give.
No, they're accepting nebulizer at home, and preferably they're accepting nebulizer rather than MDI.
No,
My
don't worry
question
about
is
their
actually,
acceptance. I think it requires a lot of education. Modi bhai, you can also pass a couple of comments.
yeah.
sir,
Chinmay,
Mohit sir is my teacher. He has explained me
Doc-
not to give nebulization without oxygen. So my approach to Modi sir, but uh, my question is it advisable to give nebulization without oxygen at home, sir?
Dr. Chinmay, please don't advise for nebulization at home. Now, at present, nebulization has got very, very minimum indications. A
Okay, sir.
very acute severe asthma where the child is unable to breathe even with tidal volume, critical ill child and in ICU.
Okay, sir.
Okay. Rest of the things can be taken care of well by spacer plus minus mask. Now this nebulizer use that you are talking about, this is the doing or undoing of we ourselves, pediatricians and lot many quacks, pharmacists, teachers who practice in the rural belt. Okay. So
No, sir.
they don't have
Sir,
any teaching, training,
uh,
awareness about the use of MDI, spacer. They can't train, they don't know. So that is why this nebulizer overuse has come up. Since last
uh,
3, 4 years, we have been
it's a
talking.
common practice in the my apologies to all the teaching faculties, sir. Its conflict is about all the faculties. 90% of the faculty of the uh, medical community. I mean, medical college. All the faculty. 90% faculties are prescribing nebulizer at home.
That's
Uh,
what. That's why. That is why these sessions are conducted.
Why do you
That
think this must be 15th or 16th inhalation therapy I'm taking? Why I'm repeating? That is because some of you might be feeling bored, sir. Why you are repeating the
no,
same
sir.
thing
No,
again and
not at the
again?
board, sir.
No, no, no.
No,
But I'm
no,
telling you
it's
Chinmay,
honestly,
I explain, sir.
we
because
keep
we have
on
been
teaching even the pediatricians.
repeating the mistakes time and again for years. Even after all the sessions, all the awareness, all the talks, all the science, all the literature evidence, we still are prescribing nebulizers at home.
That,
That is our undoing, our crime that we are doing every day. That's our problem.
okay, Madhibhai, you can come to some end.
Dr. Narendra Singh, sir, please unmute. Dr. Narendra Singh, are you there?
The question that is asked is when is the next session? Next month. Next month, and I will share. Probably the last Wednesday or Thursday of the month. Somebody is
Sorry,
asking, please update
yeah.
regarding respiratory tract
Now,
infection
Dr.
course.
Chinmay, I
Please
am
click on the
seeing,
link. Okay,
I am,
Madhibhai, you can have last words.
Dr. Chinmay,
That's
Sir,
okay.
Dr. Amrita, you know.
yeah, are you
You
there?
can go ahead. Done. Most of them are done. I think
Yeah,
they can again log in the next session and ask much more doubts.
yeah.
Madhibhai, last 1 or 2 lines from you. Now, before Modi would speak, I will tell you, I'm very thankful to Dr. Modi for accepting to be the chairperson. It is painful to listen again and again on the topics that you are already, uh, master of it. And he's also a teacher and coordinator of Advanced Asthma course and future of the respiratory chapter for all of us. I'm seeing in his eyes lot of enthusiasm to teach and continue to teach, and we are very proud of the works done by Modi Saab. Both Modis are doing very well, I suppose, in a lighter vein. And over to Dr. Modi.
Thank you, Subhu bhai. Thank you so much. And I can see in my WhatsApp chat, in the chat box, in the question answer box, that all the appreciation for this session is pouring in. And dear delegates, uh, yes, you have liked this session. You have appreciated. We really commend all your appreciation. But like Dr. Chinmay said, please go back and practice. Unless, of course, we do this session, this type of explanation, understanding, effort, labor, it comes to nuts actually, unless we practice this. Now, Dr. Chinmay was telling about nebulization. In my clinic, I am seeing lot of asthma cases and aerosol therapies, inhalation therapy. Not a single patient who comes to me for the second time is using a nebulizer. No nebulizer at home. That is the single first take home message that any parent takes back home from my clinic. If he has come for the second time, absolutely without nebulizer at home. So only by practice, by awareness, education, we will do this, and we will be able to certainly do that. Now, please look forward to following sessions about inhalation therapy from our great Dr. N.K. Subramaniam sir. Bye. For your parting words.
Madhibhai, thank you very much. And I think good night for all of you. We will share the link for the next meeting, and we will see you again. And thank you for logging in such huge numbers. I think from passionate respiratory people, we are as a team, we feel very proud that so many questions are there and so much passion to learn. And that makes us feel energetic. And thank you, ClearNet, for giving this opportunity for all of us. Bye bye from us. And I think good night.